Greetings again. This is Dr. Bill Wyatt with the American Orthodontic Society, and I'm stuck on these TMJ cases. We have about 8 or 10 or 12 women, maybe more than that have had TMJ problems that were unique and pretty well to explain, and I'm going to try to go through several of those so you'll see that different things cause this problem, where you get the retrodiscal tissue damage from different things. Like you get hit in a car accident and somebody runs in the back of it and pops your head back. A lot of people end up having their TMJ problem after a car wreck like that. Somebody hits them from the backside like that. Or if you fall and you get your jaw jammed up in there, it hits in there. You can also just sleep at night and hold it over this way, and you put too much pressure on one side and it'll hurt that way. I had an orthopedic surgeon's wife was having pain, and all she was doing was sleeping on her jaw this way. If you sit around and read a book or something and you hold your head up like this and put the weight on your jaw, your head weighs about 40 pounds on a lot of people, and you put the weight on the jaw joint like that, and you can cause them to hurt that way. And I had somebody, I think I mentioned before, made a real thick crown on the upper central here, and when they bit down, the lower tooth hit it, and it made it push it in and hurt the tooth, and so they had to kind of hold their jaw back like this, and they pulled it back, and that caused the TMJ problem. The problem of the pain is coming from the same spot, but there's many, many, many different ways. My little nephew was playing basketball, and somebody hit her jaw with their elbow like that, and just knocked the disc out of it, and she had a joint pain for quite a long while after that. You can get your wisdom teeth extracted, and they pull your jaw back and forth, and they damage that tissue around there, and it can hurt that way. And so you may have to bring them forward and let the thing heal up, and then you go back without any orthodontic work. But then there are cases that the case develops in the class 2 with a closed bite like that. It can go like the case before. All right, let's get back on this particular case. It has its own reason to cause the pressure on the joint, and we'll see what happens here. Now, this is a nice-looking young lady. Vertical height of the face is good, no problem and all that, and her smile is good. But she's got a TMJ case. She's got pain in that jaw. Well, here the upper teeth are down kind of far over the lower teeth, and her jaw moves up here and bangs, and it can't move forward, so it's putting more pressure back here. And some people's jaws grow a little bit after they get older, men especially, but men have fewer jaw joint problems than women. It's about 80% women and about 20% men is the way it turned out in our office over a period of time. But this is, her jaw wants to come out here and it can't come. So we raise these teeth and tilt them out a little bit, and this will be free to come in. And that's probably what we did here on this particular case. And there you can see the jaw, there's too much deep bite, and here you can't chew from side to side with the deep bite. You have to chew straight up and down, and that also has some effect on this. Now, so we're going to come in here and correct that problem as much as we can, and the jaw joint problem goes away. All right, we made a split and put it in here, and we got a big ramp. She can't get behind it. She has to bite up here, and this you see this wire right here, it's way up, and it's pulling these teeth up. It's getting them out of the way. And now we get them out of the way, we can alter this splint some and help it, and also let the teeth come on in forward like that. Now we put a lower splint in the bottom and fixed it where it was. She'd bring it up with just the splint fitting into the teeth right there, made it stay pretty much, kept the jaw in that forward position. Now this is 1990. There she's wearing that lower splint in the daytime and the big splint during the nighttime. And this is, she's age 25 and 7 at this point. And this was 1989, I think, right there. The bite was closed down. It's holding the jaw back here, not letting it go forward. All right, we come in there and level that out. And we took pictures of her jaw joint where it was closed together, and when she opened it, moved way out like that, left open. And that's the same thing going on the other side. Now here is the open, right open right. You see the condyle moved out here and brought it way out here. So if somebody yawns big and this tries to go up here, they'll have a fit. You have to get that back in place. All right, we elevated the bottom and we leveled the bottom teeth out and the upper teeth together, and this will start hurting. Usually it will come and the jaw will move out where you want it to. Now we open this space, and here she's got some real narrow laterals, and this lower coming down, you can see we've brought this out. And now we elevated this wire to pick this up a little bit more, and that brings this out. We could have come in with a wire to start with and pick that up. But that opened the bite, and this is 1991. And that's open on that side. Same thing over here. 91, we put her in a retainer, and these teeth were not big enough, you see, so we will have to come in and put some type of filling in between the teeth out there to hold them in that forward position. The lower, we could have closed this up a little bit and maybe not had to add to that upper that much. But there, the upper teeth were brought up here, so we'd have to do something or make a retainer that holds that space open right there. All right, this is just a big tongue problem, and now we've got it over there, and we've slid that back. We've apparently closed. No, we didn't get it closed either. All right, the bottom is looking good. There's a little bit of space right here, not great, but need to do more. So here is 1989 when we started with a deep bite, and now it is 92, and we raised that up, but we left the gap between these laterals there. You can put an extension on the teeth to bring them together. Still there, we finished it like that. So you have to fill this in and make that stay like it is there. And I don't see the finishing of it done yet. But there we kept the lower teeth, kept that out of place. And you can see she wears her retainer now with that. And we have to hold this space like that. You can come in and build this up, or crown the lateral, or you can build up with composite to fill that. But I think you leave that gap if she stops wearing that, that may come back. So that's the problem. It's 89, and there's the thing. As long as she wears that, it won't come back. The teeth fit in that. And it's 92, and that's the end of that case. Apparently, we did not bring that to close that space up in there, and the teeth may want to stay there. But it's better for the safety where it keep it from sliding back to go in and fill those gaps like that. So this is where we stopped her problem, but you can see the problem she had was the closed bite, more or less, and that caused the jaw not to be able to go forward when she chewed, and the head of the condyle was banging into the retrodiscal tissue, and that causes thing. So there's many different causes out here that make the jaw go back like that, and the condyles get pushed back and makes the TMJ hurt. So I'm going to sign off. I hope you understand what we're trying to do here, and this is not a popular type of video to come out. People don't get excited over it. But everybody that messes with teeth ought to know what happens. And the cause is usually pushing the jaw back into that tissue like that. And then if you get something and bring it out, in most of them you'll get over the pain like that. Thanks for watching, and I hope you'll join our group and subscribe to our channel. And I'll say goodbye, and we'll see you again later.